presentation at the beginning. So what is it? So they come with strabismus, and the family says that, you know, he can see everything very well actually, but you see the pupil dilatation and the vessels just at the back of the lens. And when you check the fundus, what you see is, you know, that there's something around the optic disc area, and when you focus on the anterior part, you see the retinoschisis actually. This is the retinoschisis, you see. And this was the fellow eye. When you focus on the anterior part, you see the retinoschisis very nicely. And this was bilateral massive bullous retinoschisis in a baby. So what should we do? The family says that he can, you know, follow us very nicely, he can do some eye contact, but there's only strabismus. Should we be conservative, or should we do surgery? Or if we are doing surgery, what kind of surgery? Actually, I did this one, so I just want to share it with you. I just wanted to do a lens sparing surgery. That's why I decided to do external drainage by doing a puncture to sclera choroid and the outer retina, of course. So I drained the schisis area, and retina went very nicely backwards. I mean, the inner retina went nicely backwards, and retina looks attached. And I did cryo to the, of course, the outer retinal retinotomy area, and put a small buckle just to support it, and give some air, and I left the eye like that, and it went very well. This is the post-op 2 weeks, and this is the nasal area. By doing this, I was trying to preserve the lens, you know. It was just attached to the back of the lens. If I do vitrectomy, I would most probably will not be able to preserve the lens, because it's just attached at the back of the lens. But I just wanted to see what happened. Then since the one eye did well, we did the same thing to the fellow eye. And these are the second and third month following the surgery, right and left eyes. And retina looks attached, but you see in the left eye, I can see some membranous formation, which may be the contraction of the inner layer. And I followed the case, and this was 5 months after the surgery in the left eye. You see, we can't see, but can you please show it again? We see the inner layer contraction, which caused traction over the vessels, and which is tethered between the inner and outer layer, and which caused some hemorrhage in between the inner and outer layers, and causing some tractional retinal detachment. And then, of course, I have to do a surgery for this. We did inner layer retinectomy at this stage. We have to take all those contracted inner layer, and luckily we didn't have any retinal break, and the one that we have induced for drainage was closed quite nicely, and we did only the inner retinal retinectomy. But of course, before that, we have to do posterior hyaloid removal, total hyaloid removal, and the lens was staying there, so I did lens sparing vitrectomy. And after peeling, after eating the inner retina, and it was just involving the macular area too. So just coming to, can we please continue? Coming to the macula, and then I did just some laser to the borders of the inner retinectomy area, and put air. That's it. And we did this is the first month after the surgery, and we did the same surgery to the left eye too. You can, and this is right eye, sorry, right eye too. And as you see, it didn't cause too much traction, but there were some membranous formations already, but better than the other eye, and it went very well. And these are the 6 months appearance. I used only air as a tamponade, and this is 3 years after the surgery, and this is 3.5 years. You see, retina is attached. There's only a age of the inner retinectomy, and vision is now measurable 20/400. So in those massive bullous retinoschisis cases, do not try to save the inner layer in cases of bullous retinoschisis. Of course, in such a case, just to save the lens, you can use this technique, but you should be prepared for the vitrectomy surgery. We could do the vitrectomy just at the same session, but since we have induced an external drainage doing the outer retinal retinectomy, so it may cause retinal detachment, may be more prone to, but when we do it afterwards as a second procedure, I think it protected from the retinal detachment better. So if you're not so confident with the surgery, you can even follow the surgery, follow the case conservatively. If you feel that you will harm more when you do the surgery, because these cases go up and down the retinoschisis spontaneously, and when you see it's more lower, then you can maybe decide on surgery. And I would like to invite you again to our EVRS meetings. Thank you. Ready for your questions.
Yeah, sure.
Shingle, very interesting case, but I have two questions. The first question is, you said in that some cases you need to follow up. I'm sure not those bullous cases, but what's your protocol for follow up, and when do you decide to intervene? And you said, don't save the inner retina. Actually, the inner retinal layers are usually shortened in those patients, and you cannot flatten them unless you remove them or trim them as much as you go. So how far do you go trimming those inner layers, the edges of the macula just outside the arcades where? Do you do laser or not on those areas?
Yeah, very good question. Of course, these are the important points. When I have not a bullous, but, retinoschisis cavity, mostly in the inferior temporal part somewhere, I try to, if it's not involving, it not threatening the fovea, I would do laser barraging first, if this is applicable. And it may help in some of the cases, because sometimes we have rhegmatogenous retinal detachment in one eye, the fellow eye has a localized retinoschisis, then I do laser only for the fellow eye. But in such massive bullous retinoschisis, I prefer to do surgery, as I did in this case. But, it has some tricks and it has some problems, it has some complications inside. That's why if you're not very experienced with such pediatric cases, or if you're not so confident with the surgery, then you can follow even, because it may be even better. It's not like rhegmatogenous retinal detachment. So when you feel more confident, then you can do it. Of course, when you leave the retinoschisis there, bullous retinoschisis, it may even pull more in the macular area, and this has already involved the macula, actually. That's why I don't wait. But if you're not confident, you can even wait, or you can, of course, refer to someone else. How far to go to do retinectomy? When I do vitrectomy, when I start inner layer retinectomy, I take all the, elevated inner retina. All the elevated inner retina. When you leave it, it contracts and it forms like a PVR membrane. That's why I do it. It's sometimes associated with some of the Coates cases even. When you do, Coates cases, when you see such retinoschisis, when I do vitrectomy, I also do retinectomy, even in those cases.
Shingle, just to be clear, you say I remove all the inner retina.
I mean, of course not. All the inner retina which is elevated.
Okay, but you go as far as the arcades, the macula.
Try to preserve the major vessels and macular area, the main areas, but try
and no laser. No laser on the inner layer.
I do laser.
You do
to the border.
Because it's controversial. They say it doesn't work.
Yeah, this is controversial for sure. Just to make sure that if there is any small hole on the edge of the traction area, so you just make sure that it's under control.
So we have one question, Muhammad. Yes. Gadget.
What is the when you do the external drainage, what is the chance to create an outer retinal breaks, and what is the chance of retinal detachments? In
Yeah,
this
of
case?
course, it's 100%.
Okay.
Because
so why
you
we
know
do it?
you're doing it. You can't do it without doing a outer retinal break. That's why it's like, you do it in courses, but it's under the retina. But now it's in the retina. So I did this just to try to preserve the lens, because it was just at the back of the lens. If I don't do this, if I do just vitrectomy, for example, I would probably have to take the
remove the
lens
lens.
out. That's why but I have to take care of the retinal break. I put a buckle, did cryo, and put some air. That's it.
Okay, so from your experience, most of these cases you end doing vitrectomy if you do external drainage.
This
to
was
start
very,
with.
very extreme case. I have to say that this was very extreme case. But in such cases, in congenital X-linked retinoschisis, I usually do just vitrectomy when I see bullous retinoschisis, if it is not touching the lens. But if, this was an extreme case, of course.
Thank you, Sengul.
Thank you.
So please join us. So this is the end of EVRS session. Any last comment or suggestion we can take for 30 seconds, not more. So we have already running short the time. If everything is good, thank you so much for having us.